For part two of General Medicine, the Year in Review with Dr. Allan Brett. Dr. Brett is a clinical professor of medicine here joining us, and also has his work with Journal Watch. I'll leave it. I'll leave it. Oh, excuse me. And then we'll do the same format as last week, where Dr. Brett's going to be presenting specific articles or guidelines, and after each one, we'll pause for questions and discussion on that article before moving on to the next topic. Dr. Brett?
All right, thank you, Steve. For those of you that weren't here last week or haven't joined me in this presentation in previous years, I'll just give you a 1-minute background. I'm the editor of NEJM Journal Watch Literature Review publication, which you can now access through the University Medical School Library, by the way. And every year for the beginning, in January 1st, we publish a year in review that reflects our opinions on the stuff that we've covered in the previous year that's of particular interest to many clinicians. Sometimes, as you'll see, it's a single study, sometimes it's a couple of studies on one topic, and sometimes new guidelines. Informal selection criteria, interest for primary care, general medicine, landmark studies, and if it happens to be a study that got a lot of media publicity and is important, we'll often cover those too. So here we go. Last week we covered the topics on the left of the slide, and then this week we're going to do beta blockers after MI, perioperative cardiovascular assessment, harms of gabapentinoids, perioperative GLP-1 agonists, and e-cigarettes for smoking cessation. So let's get started with the first one. And as Steve said, we'll pause after each of those segments for several comments or questions. And as I said last week, this is a whole lot of information in the 2 weeks. I don't claim to be the world's expert in any of them, so that if anybody has a point that they want to make that, supplements or even contradicts what I say, don't hesitate to speak up. All right, so here we go. It's a long-standing practice to prescribe, often indefinitely, long-term beta blockers for secondary prevention after acute MI. But the question here is this still warranted in the current era? That practice was begun several decades ago. And in the current era of frequent revascularization and use of secondary preventive therapies such as high-dose statins, does the beta blocker add anything substantial? And one reason that people are interested in this is because one would ask, do potential benefits outweigh the side effects, given that there's a perception anyway that a fair number of people who take beta blockers do get side effects from those drugs. And this whole discussion assumes that there are no other indications for beta blockers. If a patient needs to have them because they have a significantly low ejection fraction, that's not the patient we're talking about here. 2 large randomized trials were published in the past year, both in the New England Journal, and they were both from Europe. The first one involved 5,000 Swedish patients who were randomized to either beta blockers or no beta blockers immediately after MI and revascularization. That is, they had the MI, all the entrants in this study were revascularized, and they were discharged either on a beta blocker or no beta blocker. Again, with the caveat, everybody had normal ejection fraction in the study, and virtually all of them were given a statin and antiplatelet drug at discharge. The mean follow-up was 3.5 years, and they had a combined endpoint of death and recurrent MI, and it was exactly the same in both groups. And if you look at the 2 components of the primary endpoint, the death and the recurrent MI, same in both groups, and other endpoints, secondary endpoints like heart failure and arrhythmias, also were the same in both groups. So that study, conducted in this way right after the MI, showed no difference. The second study from France was a bit different. These were patients who were still taking beta blockers an average of 3 years after their myocardial infarction. Again, to get into this study, you had to have had revascularization also. And this study, like the other one, excluded patients with heart failure and other beta blocker indications. So these patients were randomized at that point, several years later, to continue or stop the beta blocker, and it could be tapered if the physician caring for the patient wanted to do that. And there was 3-year follow-up. So in fact, if you add the 3 years after the MI with the 3 years of follow-up, the final endpoint that we're going to look at here came 6 years after the index MI on average. Another composite endpoint, this is a broader endpoint, death, MI, stroke, and cardiovascular hospitalization. And this endpoint occurred slightly higher with stopping than with continuing. There's that 3 percentage point difference that you see there. This was a non-inferiority study, and the conclusion based on the pre-specified difference was that stopping was not non-inferior. I hate all the double negatives, but in fact, the conclusion is it is possibly inferior based on their chosen difference to conclude that stopping is possibly inferior to not stopping. That 3 percentage point difference was almost entirely attributed to hospitalization for coronary reasons. So it wasn't a difference in death or MI, which is reassuring. And then the other important thing in this study, which was not looked at in the other one, was that the mean quality of life, they did serial quality of life questionnaires, and they weren't different in the two groups through the study. So what this says is that even though we perceive or patients might perceive side effects, at least in this kind of a methodology, stopping the beta blocker didn't improve quality of life scores in that group compared to the continuers of beta blockers. So in summary here, the first trial with randomization right after the MI showed no difference in cardiovascular outcomes. The second trial with randomization 3 years after MI showed a small decrease in hospitalization for coronary-related reasons in those who continued to take beta blockers. One limitation is that both trials were open label, and then one would restrict the conclusions here to patients who've had revascularization. So in sum, just thinking about these results, one might say that the jury is still out, and it's probably reasonable to choose either option for now. And 2 more trials actually are pending. One reason it's reasonable, even though that concern about the inferiority, is that the big endpoints of death and recurrent MI were the same in both trials. I haven't read anybody saying this, but to me, thinking about the difference between the 2 outcomes, one could imagine the first one right after MI, patients have been revascularized, days before starting being in the study, et cetera, compared to the other one. In the second trial, with the longer follow-up and the longer duration of beta blockers, that gives more years for those patients perhaps to have developed stenotic disease or occlusive coronary disease in other arterial beds besides the bypassed one or the revascularized one, and then stopping the beta blocker might then unmask sort of latent tendency to ischemia that led to the several percent of patients who had been admitted to the hospital with ischemic coronary symptoms. So that could explain it. It seems to me that one way to look at this is if you have a patient who shows up who's been on these drugs for a number of years, just to have a discussion. If the patient does not have any other indications for beta blockers, if the patient perceives they're tolerating it okay, let's say it's a patient who the beta blocker might be helping to control hypertension, those might be the people that you would continue it. On the other hand, I'm giving extremes here. Somebody who's frustrated with polypharmacy, who has had a very stable course, et cetera, you might consider stopping it. I'll stop there. Anything on this one?
No questions in the chat yet. People, please, audience, go ahead, put those in there as they come to mind for you. I'll start with one though, Allan. These trials, did all were patients included excluded based on ejection fraction? Because I think we've also had some recent trials for post MI normal EF versus lower EF and beta blockers.
They were excluded based on ejection fraction. Um, and I can't give you the exact numbers, but they were at least alleged to have normal or relatively normal ejection fractions. They would have been excluded, presumably, if the clinicians felt that their borderline ejection fraction or whatever, a subgroup, let's say, had borderline ejection fractions, merited beta blockers. They ought to have been excluded anyway. And there was no increase in heart failure hospital admissions in either case in during the follow-up.
And Gary followed up in the chat with a similar question. The question is, should beta blockers be started post myocardial infarction in patients with a normal ejection fraction?
Well, I see that's where I think the jury is still out, and I'm guessing this is a wild guess. And if somebody knows if I don't know if there are any hospitalists or others working here, tuning in here, but I'm guessing that most cardiologists still will at least give a short course of beta blocker upon discharge and not necessarily go with the Swedish trial that stopped them right away and didn't seem any harm from doing that. So I'm not going to go out on a limb and say what the average cardiologist would recommend here because I don't do that for a living. But that's just a wild guess. That people might be skittish about doing that. And to be honest, one of the cardiologists I spoke to said, I'm going to wait for the two more pending trials. It's amazing that there's so many trials looking at this actually before I sort of make a definitive move on what I do with my patient. Continue? Okay. Potential harms with gabapentinoids. Pretty obvious to anybody who does primary care that there's a dramatic increase in prescribing of gabapentinoids for just about any kind of pain by any specialist these days. And it's likely this started about a decade ago, and it was surely in response to the opioid crisis and the mandate to limit opioid prescribing for most patients. So people were looking for options besides acetaminophen and NSAIDs and so forth. What some people might not realize is that most of the prescribing is off-label. If you look at the official FDA prescribing information for these drugs, it's as follows. For gabapentin, the only two FDA-approved indications are seizures. These drugs were developed originally as anticonvulsants, and postherpetic neuralgia. That's it. Diabetic neuropathy is not an on-label indication. Pregabalin came along after gabapentin, and under the brand name Lyrica, the company did other large randomized trials to get it FDA approved for several other indications. And you can see the list there: seizures, fibromyalgia, pain associated with diabetic neuropathy or spinal cord injury, and postherpetic neuralgia are the indications. So at least for those, there were clinical trials with enough of a statistical benefit that the FDA saw fit to approve them. But I think we can usually think of them as interchangeable. They're very similar drugs, and I think we can pretty much conclude that what works with one is likely to work with the other or not work. Sedation, dizziness are very troublesome side effects. We see it particularly in older patients and frail patients. And in 2024, what we're going to cover here is several observational studies that suggested additional harms for these drugs. This first one has to do with COPD, published in the Annals of Internal Medicine. I actually wasn't aware until this one came out this year that back in 2019, the FDA issued a warning about respiratory depression in at-risk patients for respiratory depression who were taking gabapentinoids based on case reports to the adverse drug reporting system. And this particular study here from this year was a Canadian cohort study in which 14,000 gabapentinoid users with COPD were matched using propensity score matching to 14,000 non-users with COPD. The matching characteristics included dividing the underlying diagnosis to was the drug allegedly used for neuropathic pain or other sorts of pain. It's not a perfect distinction, but they tried to do that. And what they found was a higher annual risk of in users of gabapentinoids versus non-users for both of these outcomes, a severe COPD exacerbation. It's a pretty large difference, 15 versus 8% in 1 year. This is an annual risk. And with adjustment, it remained statistically significant. The hazard ratio is 1.4. And for respiratory failure, 6% versus 4% was the difference between the two groups, and that was statistically significant also. So this study would advise us to think about if we have a patient with fairly advanced COPD, to think twice about giving them a gabapentinoid drug for whatever pain you're thinking about. The second one had to do with hip fractures. This is from Australia. Different methodology here. This is 2,600 patients with hip fractures, all of whom had prescriptions for gabapentinoids at some point in the several years before the hip fracture. And in this study, it's a pretty convoluted methodology, which I'm not going to get into here, and I actually didn't understand some of the details. But patients were their own controls, and they examined the temporal relation between the fracture and being on the gabapentinoid or off gabapentinoid. Remember, all these patients had been exposed to gabapentinoids at some time. And they found this highly statistically significant adjusted odds ratio for hip fracture during gabapentinoid use versus not during gabapentinoid use. And the odds ratios were higher in two subgroups that one might expect. The frail subgroup, seems obvious why that might be. And with CKD, that reminds us that these drugs are renally excreted, and you have to lower the dose in patients who are developing progressive chronic kidney disease. And often clinicians forget to do that, or they don't do that, which increases the risk for side effects. The presumed mechanism here, of course, would be the dizziness, sedation, leading to falls, leading to fractures. That's the way you might explain this. And the third one is edema. This is a well-described side effect from clinical trials that looked at these drugs initially, where fairly consistently edema was seen in about 5 to 10% more patients with these drugs compared to their placebo comparators in clinical trials. But I don't think a lot of people actually know about this. This study used a prescribing cascade technique, and that's a methodology for looking at one drug's side effects begetting another drug in the future after the first one's prescribed. This one came from the U.S. Veterans Administration. It was a VA study. And what they found was that among patients who were prescribed both gabapentinoids and loop diuretics during a 12-month period, the diuretic was significantly more likely to show up as a prescribed drug after than before gabapentin. And the theory is it's likely due to chasing the edema from gabapentin and not due to some other indication for the loop diuretic that just happens to show up after they were given gabapentin. There's a presumed mechanism for this, precapillary dilatation. Gabapentinoid drugs are actually calcium channel blockers in their mechanism. They bind to a particular part of calcium channel that is their central nervous system mechanism for their analgesic and anti-seizure activity. And there's some spillover to precapillary calcium channels, apparently from animal studies, that might explain the edema that we see also in people who get amlodipine-induced edema. I'm going to end this. So there's some warning shots here about the use of these drugs. And I'm going to end this with showing you, this is a topic that's interested me for a while. And back in 2019, a colleague and I published in JAMA Internal Medicine a literature review where we pulled from the literature every placebo-controlled trial we could find for gabapentin and pregabalin for a pain indication not covered in the FDA approved indications. In other words, off-label uses. We found 22 studies with gabapentin and 12 with pregabalin that fit this category. And I'm just going to show you some of them. For low back pain with or without radiculopathy, for gabapentin, there were 4 studies that had been done. 3 out of the 4 were negative, no better than placebo. And the one that was positive, it was something like 1 point on a 10-point pain scale. It was pretty small. For diabetic neuropathy, you might be surprised, 2 out of the 5 studies were negative, no better than placebo. The largest trial was negative, actually. And then they had a study that looked at unspecified neuropathy, various kinds of neuropathy, 300 patients, and that one borderline difference, 0.5 points on a 10-point scale on average difference. The P is 0.05 on the fence there. For and if you're wondering, what about the other dozen studies not subsumed by those 3 bullets? They're all over the map. Carpal tunnel syndrome, chronic pelvic pain, jaw pain from TMJ. People tried all kinds of things here. Most of those are negative. For pregabalin, 12 studies, and I'm just going to mention 2 here. One was on sciatica. This is the sciatica study for pregabalin was in the New England Journal. It's really the best study of all this 20 or 30 studies. It was a great study of people with subacute ongoing pain after a herniated disc, proven by MRI, with the pain distribution corresponding to clinical symptoms and exam. Entirely negative pregabalin versus placebo in this study. In fact, numerically, there was slightly more benefit with placebo than pregabalin in this study. It wasn't significant, and a lot of side effects in the pregabalin group. And then an unspecified neuropathy study that was negative here. So in sum, the literature is not as strong as you might expect for giving gabapentin for all of these off-label indications, and even for the on-label ones. When you see mean pain scores that aren't much different from each other, that does not exclude the occasional patients that's not the average who might benefit. But I strongly have believed that when we start these drugs, we need to have a discussion with the patient about the potential side effects and make it a time-limited trial with follow-up. If you don't perceive benefit with this drug, then we need to stop it. So I'll stop there.
We're waiting for questions in the chat right now. One that I have, so you mentioned, you described a proposed mechanism for how the gabapentinoids can cause lower extremity edema. What, if any, have been proposed for the COPD exacerbations? I can think of just general sedation, decreased respiratory rate, but I also don't know, and I'm wondering if you know, is there any direct impact on the lung parenchyma itself?
What was the last comment? You were wondering if there's any what?
A direct impact on the lungs themselves.
Direct impact on the, I'm
The
sorry,
lungs.
the lungs. Oh, I see. I believe, and it's been a while since I read that paper now, I believe it's all thought to be presumably centrally mediated. I don't recall reading any suggestion that there was anything directly pulmonary there. Okay, ongoing.
Let's
Yeah.
go.
It's just one little comment here. So I've told many of the listeners at other times, my clinical activity, I'm no longer have my own practice, but I precept at the VA in the residence clinics, and I'm just floored by how many patients have gabapentin on their med list, at least in the VA system. It seems some sessions, half the patients, it's on their list. Sometimes it's been dropped and the patient's not taking it anymore, but I think, the widespread use of these drugs is a pretty big problem in my view. Okay.
Before you move on, there is a question. So can you go back one slide? So here you did a nice job of listing all the times where the evidence does not show clear benefit for gabapentin. Do you have any medications that you know of that do have good evidence for pain in these situations?
I don't think I have anything to add to the experience of, good, busy clinicians out there. I think, it's just all over the map. I mean, NSAIDs depends on what your threshold for risking side effects in older people with pain is, and for example, neuropathy. I mean, the neuropathy problem is a big problem because any drug you look at, whether it's anticonvulsants or amitriptyline and some of these other drugs that are used for neuropathy, uh, when the studies are show some benefit, it's pretty small on average, and you really get into side effects quickly as you try to escalate the doses of these drugs in some patients. So I don't have any tricks. It's all individualized here. It's a big
Stephanie made
problem.
a
Yeah,
Stephanie made a comment, and there's agreement in the chat that suspecting we use these medications, the gabapentinoids, so much because many patients don't have adequate pain control with NSAIDs or acetaminophen, and we're trying to find alternatives to opioids.
yeah, yeah. I mean, the other question is, I don't want to get too much in the weeds here, but you know, I think that, and this has been described in the CDC's opioid guidelines, that there's been such a backlash that, I'm not telling people here, use opioids, but there's been such a backlash that in certain patients that probably should be receiving opioids, there's a lot of resistance to giving them in, a small subgroup of patients that might benefit from monitored opioid therapy. Okay, another controversy, preoperative GLP-1 agonist use. So this controversy involves the use of these drugs heading into a procedure that involves sedation or general anesthesia. And it became controversial when various case reports were published of patients who were on these drugs and then had unexpected pulmonary aspiration during or after procedures involving anesthesia. And the mechanism of the concern is delayed gastric emptying that these drugs cause, leading to aspiration. I'm going to start on this slide with two studies done in the last 2 years. One was a study of about 200 patients with diabetes who were taking a GLP-1 agonist and undergoing upper endoscopy compared to 200 matched patients not taking a GLP-1 agonist. And in this study, the endoscopists found a higher incidence of retained gastric contents at EGD in the GLP-1 group compared to the controls. The second study here, published this past year in JAMA Surgery, 62 patients on GLP-1 agonists compared to 62 controls on the morning of surgery. I guess they're in the waiting area before going to surgery. And the researchers did point of care gastric ultrasound in all of them. And they found a higher incidence of residual gastric contents. Doesn't really say how much, but this was ultrasound based with GLP-1 agonists compared to people who were not to controls. And in multivariate analysis to control for differences between these two groups, there was still a statistically higher appearance of residual gastric contents on ultrasound in the GLP-1 agonist group. The ultimate question, however, should be, do the retained gastric contents actually increase risk for pulmonary aspiration, aside from these individual anecdotal case reports? In 2024, two retrospective studies were done, one in BMJ and one in anesthesiology, where they looked at patients with diabetes who were undergoing upper endoscopy. And neither study showed an association between GLP-1 agonists use and pulmonary aspiration. but there's severe limitations here. These are both large database exploring studies. One took it from commercial claims database, the other took it from EMRs, and we all know that it's sometimes perilous to rely on those because of inaccurate coding and documentation. But that's all we have really here. Now, during the past 2 years, separately, the American Society of Anesthesiology and the American Gastroenterological Associations have issued, quote, guidance statements. They're not formal guidelines, but they're statements about whether to hold these drugs before the procedures. They're both very short statements, and they're a bit wishy-washy, understandably, because the data to support one approach or other are not great. In October 2024, which is where we're going with this segment here, finally, the two societies got together and issued a joint statement, and that's what I'm going to finish discussing. This joint statement is published in the Clinical Gastroenterology and Hepatology. The reference is there. By the way, as I said last week, you were emailed the print issue of Journal Watch. It has all this stuff in it, so the references are all right there. And as I said, you can access Journal Watch online too, through the university. So this was published, and it's only a 2 or 3 page document. It's very short. And what they're asking you to do is consider the following variables as elevating risk in GLP-1 agonist users. And they list 5 characteristics. Is the patient in the escalation phase of dosing? Is the patient on a maintenance dose that's high? Is the patient taking weekly versus daily dosing? Because the risk from other research of effects on the stomach tend to be greater according to the guideline, the statement, with weekly injections versus daily dosing. And I'm not really sure how many people are using daily doses of the other agents other than semaglutide anymore. Although there's the oral semaglutide that's a daily dose. Presence of gastrointestinal symptoms, which is obvious, and then presence of other conditions that might delay gastric emptying, like diabetes-related gastroparesis or neurologic diseases that impair autonomic function. So what they say then after they give you this is continue the GLP. It's okay to continue the GLP-1 agonist in patients who are not at high risk. Now, if you look at that, when I read that, it immediately looked somewhat problematic to me, because if you look at those 5 things, the first 2, most patients are either in the escalation phase of dosing or they've gotten to their high maintenance dose. Yes, there's a subgroup of people who end up plateauing at a low dose and continuing at a low dose, but that's probably a minority of patients. So if you just look at it that way, almost all patients will end up being considered at high risk, using those bullets literally. Then the next segment of the statement is if the patient is considered at high risk based on the above things, then, quote, balance the potential benefit of withholding the drug against the risk of inducing hazardous hyperglycemia. My problem with that one is that it seems pretty unlikely that for the vast majority of patients, omitting one dose, either a 1 daily dose the day before or 1 weekly dose, is going to lead to hazardous hyperglycemia in the vast majority of patients going into the surgery. It's not like if you would stop insulin in a patient who depends on insulin cold turkey a couple days before surgery. So I was puzzled that they made such a big deal out of that. And then going on the statement, they ask people to consider a preoperative liquid diet for at least 24 hours, an extended liquid diet when there's high concern for delayed gastric emptying. And then finally, they finish with, if the patient shows up on the day of the procedure falling through the cracks and hasn't been seen preoperatively to address these things, and they took their shot of the GLP-1 agonist a few days before, either consider gastric ultrasound point of care, and then they go on to say, but a lot of centers aren't equipped to do that reliably. Consider rapid sequence induction or intubation, which is supposed to lower the risk of aspiration. And or consider canceling the procedure. And the guideline does mention a lot of the uncertainty about all of this, and it emphasizes collaborative approach among the clinicians who are caring for the patient and shared decision-making with the patient. And I'll end this with just saying that in my precepting at the VA and getting to know the primary care clinicians there, some of them have told me that the gastroenterologists at the VA are requesting that these patients pretty uniformly have the drug withheld the week before the procedure. And most of them are doing that to prevent the procedure being canceled when the patient shows up and tells them, hey, I just took my my semaglutide or my tirzepatide. I've also spoken and a couple of Journal Watch editors to some anesthesiologists and gastroenterologists in other places, and our impression is that this is still all over the map depending on what center you are and the individual GI person or the individual anesthesiologist that's responsible for the individual patient. So it's still somewhat unsettled. Seems to me that in the average case, there's virtually no harm in holding one dose and thereby ensuring that the patient's not going to have their procedure canceled. Stop there.
So we have discussion in the chat about the once daily GLP-1s. There's some people that working at FQHCs, patients without insurance are on daily GLP-1s. Colorado Medicaid covers dulaglutide and also covers liraglutide on the formulary. And then Annie also said that liraglutide has become generic, and this was news for me. It actually just became generic back in December, and that she's seen more daily injections due to the overall lower cost. And she's wondering your thoughts on timing for discontinuing the daily GLP-1 before surgery.
If I understood correctly, the guidelines or the guidance statement is asking you to drop the dose the day before. And I haven't done detailed research, but the pharmacokinetics are, according to them, that it's fairly quickly reversible and the effect on the stomach, and that it does distinctly say drop, if you're going to do this, omit one weekly dose during the 7 days before and omit one daily dose for people who are on daily the day before the procedure. Okay. Keep going.
Keep going.
All righty. The next one I hope is not too redundant, perioperative cardiovascular management. You had a full grand rounds on this topic by Molly Brett in November, and this is a pretty big deal for general medicine. So and it was one of our year in review topics. So I'll just briefly go over with a couple of highlights here. And this has to do with the brand new American College of Cardiology AHA guideline on cardiovascular management in preparation for non-cardiac surgery. The previous version of this guideline was 10 years ago. Now, this is a 100-page document. It covers a huge range of anything you can think of cardiovascular-wise for a patient who will be undergoing non-cardiac surgery. I'm just going to focus in these couple of minutes to a couple of issues relevant to preoperative assessment by generalists. And in particular, what they call the quote stepwise approach, which is summarized in an algorithm, which is sort of in the middle of this paper. And I'd encourage you to access this and maybe print that out. The print's so small, it was too tiny to try to show you in a slide. And the algorithm is the same algorithm that appeared 10 years ago with a few tweaks and modifications, which I'm going to show you. First of all, at the outset, there's no need to go through this algorithm. If it's a young or middle-aged person with no risk factors, they can go right to surgery. If it's a surgical condition that's an emergency, then that has to take precedence in whatever you do. Or if it's a patient who has unstable cardiac symptoms, whether it's coronary arrhythmia, heart failure, and it's elective surgery, those patients have to have their cardiac instability stabilized. But if you have a patient that doesn't fit the above, and by that, we're talking about moderate to higher risk people with some risk factors scheduled for elective surgery, the next step in the algorithm is to use a risk calculator. And I think most people are still using the RCRI. It's a pretty easy 6-point tool, but they basically are neutral and they recognize several other ones. The other ones that are available are more complicated, require more input variables. And they also tell you to look for risk modifiers. So these are things like patients who have valvular disease, say aortic stenosis, or known recently active coronary disease, pulmonary hypertension's on the list, a few other things. If a patient has risk modifiers, then they recommend, quote, team-based consultation without telling you what that means, but I assume it's getting together with the surgical team and maybe cardiologists and figuring out whether it's safe to go through. If the patient doesn't have risk modifiers, but is at above average risk by a calculator, and for RCRI, they count above average, high risk as anything more than a score of 1 on that one. Then you go to the next point in the algorithm for that patient. And that goes to the assessing functional capacity. In the old algorithm, they recommended using metabolic equivalence, METs, and the recommendation was that if the patient could do 4 or more METs, which basically translated to being able to easily walk up a flight of stairs, that counted as adequate functional capacity to move forward. The new one introduces the Duke Activity Status Index, and there's a sense that they favor that one, and there's good reason to favor that one if you're going to use something here, because studies published during the past decade show that it's a better predictor of postoperative complication than using METs. I believe it's a 12-question, I think 58-point index. So it takes longer to do than just saying, can you walk up a flight of stairs, obviously. If a patient is capable of doing 4 or more METs, or if their DASI score is greater than 34, that's from other research suggesting that's a reasonable cutoff for a good functional capacity, proceed to surgery. However, if the patient has a lower score on either of those, or they have unknown functional capacity because they really can't exercise because of their orthopedic or neurologic condition, then the next question, and this is a direct quote from the algorithm, is will further testing impact decision-making or perioperative care? And, that's always an interesting thing because it's a very subjective comment. They're asking you now to make a somewhat subjective or intuitive judgment at that point. If your answer there is yes, this is the other new thing in the calculator, in the algorithm was not there 10 years ago. They recommend doing a BNP or an NT-proBNP. That's their first line one. And then they say you could also consider troponin. This is pre-op, right? And that comes from a couple of large observational studies that showed that these biomarkers checked pre-surgery can predict a higher risk of post-surgical, post-operative adverse outcomes. If the biomarker is normal, they recommend proceeding to surgery. And of course, here, you're going to have to depend on what your lab's normal upper limit is. If the biomarker is abnormal, then we have another one of these subjective or individualized comments, multidisciplinary team discussion on risk of benefits of additional cardiac evaluation. And that's pretty much where it ends. In sum, functional capacity and biomarkers can be used in the new algorithm to kind of narrow down the subgroup for whom additional evaluation, quote, might be considered. But you end up kind of in some limbo there because exactly who you should do additional evaluation remains somewhat controversial. And I'd like to point out here that literally 2 decades ago, there were several randomized trials looking at taking high-risk patients and doing stress testing at the end of their algorithm, or doing even coronary angiography in a large VA study, and then revascularizing certain people before their non-cardiac surgery. Remember, these are all asymptomatic people. These studies basically showed no overall net benefit to doing those downstream things before the patient goes to non-cardiac surgery. So we're left both in this final point and with biomarkers, if they're elevated, knowing exactly what to do with the information. But that's what the latest guideline says, and I'll stop there. Let me just see. Yeah, oh, I'm sorry. One more slide here. I mentioned it's a 100-page guideline. There's all kinds of other stuff. I'm just going to put a couple bullets here. They recommend consider delaying surgery in patients with cardiovascular risk factors and a blood pressure greater than 180 over 110 just prior to surgery. How do they come up with that cutoff? It's based on old observational data that I'm not sure how applicable it is these days, but that's what they recommend. Consider 24-hour hold of ACE inhibitors or ARBs in selected patients. This comes from anesthesia literature initially that showed that patients who take these drugs are at slightly higher risk of inducing hypotension during induction of anesthesia. And a couple of randomized trials in the last 2 years show that if you hold these drugs, the patient has a modestly lower chance of having intraoperative hypotension, but neither of the studies showed differences in major clinical adverse outcomes at 30 days. So what I have done here, and I think the guideline actually sort of hints at this. If you have a patient on an ACE inhibitor and ARB who's had very tightly controlled blood pressure as an outpatient, very lowish readings, consider holding the drug. If the patient's been hard to control, they're on an ACE inhibitor and ARB, you might continue it right through the morning of surgery. And this all applies to people on the drugs for hypertension, not for people who have heart failure and are on these drugs. Continue long-term beta blockers through the perioperative period. Don't stop them cold turkey the day of the procedure, the day before the procedure, for fear of inducing.
So when I'm logging in from that screen, you have to do university and then backslash
Allison, you
your login
accidentally
name,
unmuted
and
yourself.
then
I'm sorry.
Allison,
Okay. And then there's a strong recommendation to hold SGLT2 inhibitors 3 or 4 days before surgery because of the small risk of inducing DKA. And they also go into holding GLP-1 agonists, similar to what we talked about in the previous segment. Let me stop there.
you summarized that so well that there are no questions.
Okay. I summarized it so well, and it's still a lot of open-ended questions about how you're going to use this in any individual patient. All right, final segment, e-cigarettes for smoking cessation. Another ongoing controversy. We covered 2 randomized trials in 2024 that I'm going to show you the results. One was a randomized trial from Finland that included 460 adults, mean age of 50, median smoking history of 33 years, and everybody in the trial smoked at least 10 cigarettes daily. This was a placebo-controlled trial that created 3 groups: varenicline, versus nicotine-containing e-cigarettes versus double placebo treatment for 12 weeks. The placebo for the nicotine-containing e-cigarette was a non-nicotine containing e-cigarette. All participants had motivational interviewing directed towards smoking cessation. And the primary outcome was abstinence at 6 months, both reported and confirmed biochemically. And it was significantly higher with both varenicline and the nicotine-containing e-cigarettes, 44 and 40% respectively, versus 20% with placebo. A secondary endpoint was abstinence at 12 months, and you see both the varenicline and the e-cigarette groups are declining a bit as the next 6 months pass, still higher than the placebo group, but a bit more separation, a few percentage points with the two active treatment groups. Withdrawals due to adverse effects were more common with varenicline than with e-cigarettes or placebo. So again, both of these interventions had decent success. I think if you look back at randomized trials going back years of all kinds of interventions, whether we're talking about nicotine replacement or other drugs, when you get a 10 or 20% benefit at 6 to 12 months, you're doing pretty well. The other study was a randomized study from Switzerland, 1,200 adults, median age 38, median number of cigarettes a day was 15, and the median duration of smoking was 16 years. So most of these people started smoking in their early 20s, or at least on average in their early 20s. And the other study didn't mention this, but this one, they explicitly showed that nearly all had previous quit attempts. They don't say with what modality. This was an open label study comparing e-cigarettes plus counseling versus counseling only. Nicotine replacement therapy was also permitted, but was used extremely rarely according to the tables in the chart, in the paper. And another 6-month continuous abstinent endpoint, 29% with e-cigarettes versus 16% with counseling only. And the 13 percentage point difference there is highly statistically significant. One interesting thing that this study looked at, it's not mentioned explicitly in the other study, is that about 40% of people in the e-cigarette group were still using e-cigarettes at 6 months, most of them nicotine containing, some without nicotine. And those 40% were found both in the abstainers from tobacco and in people who were still smoking tobacco, conventional cigarettes. So I'm going to end this one. I found the editorial for the New England Journal article, that's the Swiss study, to be quite interesting. The editorialist, Nancy Rigotti, is the director of a tobacco research and treatment center at Mass General Hospital in Boston. And she's widely published in smoking cessation. She's the author of both the smoking cessation and the vaping chapters in Up to Date, for example. And the editorial kind of gives a sense of the evolution of her thinking over time. And this is a direct quote. She basically ends the editorial with, after reviewing the whole literature, it's now time for the medical community to acknowledge this progress and add e-cigarettes to the smoking cessation toolkit. Clinicians should be prepared to have a risk-benefit discussion about e-cigarettes with their patients who smoke and recommend a trial of the products in appropriate situations. U.S. public health agencies and professional medical societies should reconsider their cautious positions on e-cigarettes for smoking cessation. If you read between the lines here and other stuff that she's written, I think when she says inappropriate situations, she's talking about this being in the toolkit, but a secondary intervention for people who either refuse to or don't tolerate other more conventional approaches to smoking cessation. So this is still a fraught, highly controversial topic about, is harm reduction appropriate here, et cetera. And for people that are interested, about 6 days ago, I think it was February 12th, in the New York Times, it was a very interesting op-ed piece by an editor, an opinion editor, who's written about this topic. It's called "The Hard Truth About Nicotine," and there's some interesting stuff in there. This is a writer who favors advocating e-cigarettes as a harm reduction strategy, and she gives her arguments against the people that are against doing this. So it's a pretty interesting piece. But I'll stop there and see if anybody has any added final comments here.
So a question and then some comments. The question that I'll start out with, John was asking, so in these trials, if patients continued to use the e-cigarette, were they considered abstinent?
The study, the answer is yes. In other words, if the person stopped using conventional cigarettes, they were considered abstinent. And there's a table in the chart that's pretty convoluted. It's kind of hard to read. That gives all the combinations and permutations in the abstainers, in the non-abstainers, who was still using e-cigarettes. Did they have nicotine in them? Did they not have nicotine in them? The persistent users. So all the combinations and permutations are listed there. But the answer is yes. Abstaining means abstaining from conventional cigarettes.
Christine made comments for, I'm going to paraphrase, but harm reduction. E-cigarettes are likely to be less harmful than traditional cigarettes, but still more harmful than nothing. And that she also has patients that sometimes try to reduce or abstain from traditional cigarettes by using e-cigarettes. Then sometimes they're using a combination of both, and that the amount of nicotine in e-cigarettes is potentially different than what's in a traditional cigarette. And so there's some patients, both because of that, as well as locations where they can use e-cigarette, they're being exposed to overall higher amounts of nicotine from the e-cigarette.
Yeah, the New York Times op-ed piece talks about that, and she believes, and I'm not an expert here, the author, she believes that potential harms of nicotine chronically have been overstated by people who are against this harm reduction strategy. The other thing she mentioned in that editorial, again, we're talking about the New York Times a week ago, not Nancy Rigotti's piece or whatever, is that there's epidemiologic, there's survey data of high school students that show that both e-cigarette use and tobacco cigarette use has decreased over the past 5 years. Both of them have decreased. And the point she uses that, I think, as a point to say that the availability of e-cigarettes among high school students has not necessarily led to increasing transition from e-cigarettes to tobacco conventional cigarettes. So, and she also, yeah, go ahead.
Oh, I was going to say we are at time, so
Okay.
I'm going to wrap it up for additional comments. But thank you everyone for the questions, comments that have come on in, and Dr. Brett, thank you for this part 2 of a really wonderful talk and series. And for the audience, please join us in 2 weeks on March 4th for updates in cervical cancer screening.
Thank you, everybody.